especially the right wing, you know. Okay, so Mr. David is already here. Mr. David, PhD, is the founder and director of the Center for Medical Tourism Research for the Academic Research Center, devoted to medical tourism research. He is also the tenured full professor of management in the HEB School of Business and Administration at the University of Incarnate Word in San Antonio, Texas, USA. Before that, Dr. Vequist was an executive for Vequist Healthcare and previously was a consultant for Ernst & Young. Okay, welcome.
Thank you. All right, I'll try to use the mic a little bit here, but I'll project as much as I can. So one of the interesting stories in medical tourism is that it is one of the most free market aspects of healthcare that has arisen, at least the modern version of medical tourism, within the industry. One of the stories we like to tell a lot is it's kind of like the old story about the bear in the wilderness. The two joggers are going through the wilderness and they see a bear, and one of the hikers, joggers, reaches into their backpack and they pull out faster shoes, pull out some tennis shoes, and they put it on, and the other hiker looks at him and says, "What are you doing? You can't outrun a bear." And the person says, "I don't have to outrun the bear, I have to outrun you." And so what we're finding is in terms of both domestic and international tourism, we're seeing this great competitiveness that's going on that's actually increasing the efficacy and increasing the access of healthcare to people around the world. And so we're going to be talking a little bit about that, and specifically what's happened in Asia. All right, so we're going to briefly talk a little bit about the center and myself, medical tourism, what it is, and then we're going to be talking about how you can talk to collectivists and statists about healthcare. You're going to find that this is one of the most controversial areas that you're going to be discussing with people, and then specifically talk about Asian medical tourism and the benefits that they've seen. So the center is an academic research center. The people that work in the center are typically professors, graduate assistants, occasionally visiting professors and other scholars. We're focused on the truth. We're prepared to talk about the good, the bad, and the ugly when it comes to competition and patient consumerism and the growth of globalism when it comes to healthcare. So. The drivers, I'm a very simple person, so the drivers to me have always been pretty simple, which is it's basically a combination of the technology, particularly information technologies that make data and information, like the protocols from Johns Hopkins are found all over the world in facilities in places like Asia and Latin America and Africa. So that leads to, technology leads to more globalization. Globalization and technology together combine to create more consumerism, and that's what's happening in the healthcare, which has been perhaps one of the most resistant industries in the world when it comes to globalization. But now we're seeing extreme globalization in this area. So my background and why that's important is I have a background in both healthcare administration, consulting, particularly in the area of outsourcing, and also been a professor for a very long time now, almost 20 years, as well as a consultant with most of the major medical tourism countries in the world, both the government entities as well as providers and facilities around the world. Also worked with med tech companies, pharmaceutical companies, a variety of them. Done white papers for the UN, done research for a variety of entities, and published in the area as well. So basically what that leads to is what I believe is the coolest trend in the world when it comes to healthcare, and actually one of the fastest growing industries in the world over the last almost 2 decades. So there's been industries, whether it's apps or whether it's now blockchain or artificial intelligence, things like that, that have been growing faster. But quite frankly, medical tourism has always been one of those ones in second, third place. In fact, there was a suggestion I think it was just the beginning of this year, that in India, which has a very mature medical tourism market, they're still seeing double-digit growth, upwards of 20% growth in the medical tourism market in India, that has been seeing international patients for years and years and years. So even in mature markets, it's still growing very quickly. So this has been around forever. Medical tourism, health, wellness, health-seeking behaviors, particularly either regionally or outside the region, say internationally across sovereign borders, is as old as civilization. When I was working with the Egyptian government back in 2010, they weren't able to pay me a lot, so what they did was they gave me a trip on a Nile cruise trip instead. They said, we can't really pay you, but if you do this like 4-day training session, we'll give you a Nile cruise. And I was like, sold American, done, right? And so this was right before the Arab Spring. I was very fortunate. I was there approximately like a month or a month and a half before the Arab Spring happened. So I got to go on this now. One of the great things is we had this tour, and we got off, flew down to Aswan and close to the Sudanese border, and then we're coming up the Nile. And we stopped in a temple, and there on the walls in hieroglyphs was a formulary for a variety of different herbal and other types of cures for various types of diseases and maladies of the age. And there's some suggestions in biblical literature that it was considered at the time that the Egyptian physicians were the best in the known world at that point in time. So people used to travel to these temples to see the physician priests that would then give them these formularies, give them these treatments. So this has been around forever. The Romans also went to what's now known as Switzerland and Turkey for balneotherapy, which is, as we talked about, the Latin roots of spa therapy, which that culture still exists in Europe and places like Asia today. A lot of this is driven by the internet. In fact, if you look at some of the studies that have been done, for example, a very famous study by Pew Research showed that, and I'm going to ask a question. If you guys were in Poland with me, I apologize, it's the same joke, but please don't answer, let the other people enjoy it. What is the most common uses of the internet? And please keep your minds out of the gutter, okay? Number one is? Huh, no. Not Google. I'm sorry? Facebook, close. No, that is second. Email, it's the killer app of the internet. That is what almost all of you, or a lot of you are doing it while I'm speaking because you're like, wow, this is kind of boring. I just catch on my email. So yes, email is the killer app of the internet. It's number one use of the internet. Most utilized app, if you will, on the internet. Number two is, count on somebody under the age of 35 to point that out. And you are under 35, right? Yeah. Yeah, so yeah, you know. Social media is number two. In fact, there was a Baylor study just a couple of years ago that said that co-eds were spending, you ready for this, about 10 to 11 hours on their phone during the day. And I was like, what the heck, man? What do you do with the rest of your, I mean, you have to sleep 8 hours, and you're supposed to be going to classes and studying, which obviously they aren't, unless they're doing it on their phones, which I don't think they are. Anyway, so it's really crazy. Anyways, technology, the second thing is social media. The third thing is, you ready for this? Looking for healthcare on the internet. Isn't that fascinating? Yeah, Google did put out some results that showed that it was basically one of every, I want to say 20 searches that was done, but it's the most ubiquitous, that and food arguably, and I guess sex, which accounts for one of the other high things that people do with the internet. But the big thing that people do is they search for healthcare. And if you think about it, if you got a call from a close relative of your mother says, I have a lump, what's the first thing all of you are going to do? Yep, that's exactly right. And so technology leads to more searches for healthcare, and that's led to more patient consumerism, health consumerism. There's some wild estimates out there in terms of what how much money is being exchanged around the world in terms of health tourism, wellness tourism, medical tourism. There's a bunch of different categories, but I all kind of group them all together. There's a lot of similarities between all that, whether you're going for dental or pharmaceutical or deaf tourism, which is something we might talk about here in a little bit, all kind of the same. Here's some of the different things that are aligned with medical tourism. I'll just touch on a few of these. If you're familiar with the American app Groupon, did you know that over 60% of the things that are on Groupon are health or wellness related? Isn't that crazy? Yeah, there's the Google searching. Rating sites. Rating sites have become big in healthcare. We have a variety of rating sites for both hospitals, for providers, the clinicians themselves. It's pretty amazing what's going on. And then there's also been this amazing convergence in facilities. If you go to modern facilities, particularly facilities that are engaging in medical tourism, you can't tell if you're in a hotel or if you're in a resort or spa. It all looks like the same thing. There's some dentists that are actually trying to encourage people to come to their dental facilities by offering, ready for this, foot massages while you were getting dental procedures. So we're seeing this amazing convergence between hotel, hospitality, resort, hospital, spa. It's all kind of coming together. All right, so let's get into some of the numbers. So it's apparently medical tourism is not for everybody. Early on when we were studying the empirical research, there was very little of it at the time. I've been considered one of the leading researchers in the world on the medical tourism, one of few faculty or academic researchers that actually focus on this and have for over a decade now. And one of the things that we all expected was this was going to be perhaps male-dominated. Because we found, for example, corollaries in financial risk-taking behaviors and said, there's mostly men. Mostly men are like, sorry, for those of you into Bitcoin, I apologize, I'm not insulting anybody, but men tended to be more into Bitcoin than women because it was perceived to be a risky financial decision. And so it was typically men and perhaps even younger or more aggressive, more testosterone-filled men. So we expected that in medical tourism, but that was not the case at all. It turned out it was women, particularly women, say, over the age of 35, that were making most of the health decisions in their household. And by the way, that's true almost the world over, that women make the majority of healthcare decisions. So, additional data we found was Gallup a few years back looked in Asia, and they found that about 1 in 5 Asians travel within their country at least for healthcare. And if you're familiar with China and Chinese healthcare and the Chinese healthcare situation, you know what I'm talking about. If you're in Western China, people don't go to the public facility. That's where you die. And so what they do is they wait until they can save a couple nickels together, or yen, I guess would be the proper analogy, and then they go to the eastern coast, to coastal large cities, to go to a better healthcare facility when they have the chance to. The travel aspects are integrated with healthcare, particularly healthcare choice anymore. So when people are asked about why they're traveling, you see these statistics up there. Typically, quality, cost, and availability are kind of the mix of what the main purpose. Now we'll talk about the Michael Porter book in just a second briefly, but essentially some of those things are interlinked together. In other words, what you want is a quality procedure at a cost you can afford, correct? That's what Michael Porter calls value, from a very famous book he wrote in the healthcare area. And accessibility or availability of a particular procedure is actually a major reason people travel. In fact, in Europe, it's the #1 reason, interesting, that people cross borders, is where most of those countries have socialized medicine, but not all procedures available. So what do? They travel outside the country for procedures that are not readily available. All right, so I'm going to tell you some interesting medical tourism stories, some stuff that you guys are hopefully going to like. Some of these are a little controversial, but so hang on to your seats, and you can put your seatbelts on. They're under the seats, and let's go. You ready? So Venezuela and Cuba, what do you guys know about the situation that happened there? The most recent news is that Maduro, apparently in the last election, where's Pedro? I'm looking, I don't see, is he out there? Okay, so he's probably familiar with this. Maduro apparently brought in Cuban doctors, which have been supplementing nations around the world, particularly Venezuela and African nations, and said, hey, listen, before you give care to people, make sure you ask them, are they going to vote for me in the next election? If not, no care for you. Yeah, so that was in the New York Times, I recall. It was an article not too long ago. You're probably also familiar with the older story that Hugo Chavez was receiving cancer care in Cuba. So he actually was flying in fact, I think if I'm remembering correctly, he might have died in Cuba, and his body was flown back to Venezuela. A case not too far away in Southeast Asia, baby GAMMY, the Australian couple flew for surrogacy tourism into, sorry, some of the people that have seen a couple of these presentations, a couple of these stories are familiar, flew into Thailand for surrogacy tourism. They implanted several embryos, and obviously a couple of them took hold, one of which had Down syndrome. The Australian couple then showed up to collect their, what they thought was baby. They found out there was two, probably a young couple. They panicked. They grabbed the child that did not have Downs. They rushed to the airport and they flew to Australia, leaving the Downs child in Thailand. The surrogate mother ended up petitioning the Australian government, got Australian citizenship for both herself and the baby, and also got Australian benefits for both of them. Anybody? Help me out. Gangnam Style. What's it mean? Koreans? Anybody speaks Korean? South of the river. It's a place that has more cosmetic surgery, reportedly, per capita than any other place in the world. It's well known for Chinese tourists that come there for everything from eye procedures to other type of cosmetic procedures, including things like skin whitening. People want to look like K-pop stars, and so that's why they tend to go to Korea. The Korean soap operas, if you're in Asia, many people know about the Korean soap operas, and also the K-pop boy and girl bands. So this is the former president of Nigeria, as I recall, who, this is him getting off of a private jet going to London for cancer surgery. This has become very controversial in many African nations. In fact, now many African nations have into their constitution, they've written in that the chief executive officer, the president, cannot leave the country for health care, because it's become a big issue. You probably heard about this. The indictments just came down 3 months ago from the feds. There was a Chinese tourist that were basically going into the United States, and they had a maternity hotel. Now, this has been going on, for those of you that are familiar in the United States, this has been going on for years and years and years. The term that some suggest is kind of crude is an anchor baby, where Mexican nationals will come in and have their children in the United States so that they can get a U.S. passport. In this case, the Chinese were doing it, but the feds decided to lock them up, which I'm not sure if that's some type of discrimination or something, but apparently the reason was that when they had filled out paperwork for getting visas and being able to bring people over to the United States, they had said some things incorrectly or written down some things incorrectly, so they got them for some type of charges around that. Interestingly, they got the agenda of the women that were there. There was like 19 Chinese women in this last batch that got rounded up by the feds. They wanted to do things they couldn't do in China. So one of the things they had planned to do in LA was the gun range. Can you imagine 19 pregnant Chinese women sitting there with AK-47s and shooting them at a gun range? I think that's just fabulous. This is an example of a gentleman that had passed away after receiving surgery in Malaysia. He'd gone to Kuala Lumpur for some type of, I think it was gastric bypass, bariatric surgery. And he ended up not being correctly stapled together, right? And he bled out. And so one of the issues that came up was he was an Australian citizen, as I recall. One of the issues that came up is the Australian doctors were going like, look, people die when they travel abroad for health care. The thing that they never bring up is what are the percentage of death after surgery. It turns out people die, you ready for this, in Australia after they get surgery too. It turns out every country has deaths. What we don't have good data on is the comparison of, in many cases, efficacy and also in the adverse impacts or the outcomes afterwards. And so it's unfair to make these comparisons to say everybody dies that goes internationally. That's not true at all. This is one of the more interesting controversial ones. The Iranian religious leader, Khomeini, had issued a fatwa back in many years ago, and I apologize, I'm forgetting the date now. Anyways, that basically if you are a gay or a lesbian, that you needed to convert your gender to the opposite. So if you were male, you need to be female. If you're female, you need to be male. jail or you would be stoned to death under Sharia law. So the Iranian physicians, particularly the gender reassignment surgeons, became very proficient because many Iranians would choose that option rather than death. And so now, actually, Iran is one of the leading places in the world, interestingly enough, many of you probably didn't know that, for gender reassignment surgery. Yeah. Physicians got good at it because they did it a lot, and so they became incredibly proficient. So this is the Newfoundland premier back in 2010, left a socialized medicine. If you're American, you always hear the Canadians and the British, and they're very proud of their medicine. Well, this premier, which is basically kind of like a governor, but a little bit more prestigious in Canada, decided that he wanted to go to Florida to get a heart surgery because he liked the provider better in the United States, and he wanted to pay in cash. So when he got back there, the Canadian press was roasting him and going, "What the heck, dude? We got great health care here. You don't have to pay for it. It's free, right? Paid for by your taxes." And so he responded back to the press very succinctly, "It's my health, it's my choice." All right, in India, they established many years ago a medical tourism visa, which they track people that come into India. The largest group of people that come into India are from Africa. Africa has a population of a little over 1 billion right now. It's the fastest growing continent in the world. In fact, at some point, perhaps 100 years in the future, about 1 of every 4 people in the world will be African. In fact, Nigeria, perhaps within less than 50 years, will outpace the United States in terms of population growth and become the 3rd largest country in the world. So the fact that they're traveling elsewhere for a place like India has been an incredible boon for the Indian healthcare industry. In the United States, we've seen the growth of bundled contracts. Many large companies like Boeing, Lowe's, Walmart, Pepsi have started to find centers of excellence and send their employees there. In fact, it used to be voluntary up until a couple months ago, where Walmart just issued a new press release where they said, yeah, we're telling employees, if you want us to pay for it, you got to go to Johns Hopkins, or you got to go to the Cleveland Clinic, or you got to go to... And so basically what they're doing is they're directing them to centers of excellence, because the centers of excellence typically have better outcomes, and they have lower bad outcomes of greater efficacy, better, like infection rates are lower, things of that nature. So what they get is a better quality product, and they negotiate prices with both the physicians and the hospitals, and they negotiate a volume rate. And then based on that volume rate, there's some suggestions in the literature. A consulting firm, I think it was Hewitt, estimated that one case could potentially save Walmart up to $60,000. Walmart has about 1 million employees in the United States. So one employee, $60,000. Let's say 1,000 employees went, that's money, right? Pretty incredible. All right, so let's see, there we go. Also in Korea started a pretty interesting program a few years back. They said, if anybody comes to Korea and they don't get the health care that they want, deserve, these are international medical tourists, we'll give them a warranty. Basically, we'll make it right one way or another. It's typically mediation, but they will go as far as to refly you out there to give you another surgery. First country warranty, isn't that crazy? A British NHS physician had recently suggested that based on his calculations, he's a budding health economist, and he took what he was seeing in terms, he's an oncologist as I recall, what he was seeing in terms of foreign nationals that fly to London in order to get access to health care. The Africans, by the way, have an old saying that London is a great place to die. And they will actually, if they wait until they get sick, and then they fly to London, they get off the plane, they walk into an NHS hospital and go, I'm sick, I have cancer, cure me. And they basically get care for everybody free, right? Yes, yeah. So the taxpayers pay for it. Well, the British government has looked at the situation over the last few years, and they have come up with one kind of solution. They said basically one time is fine, but second time you can't come back into the country until you pay us back a portion of the fees. So that's supposedly what they're doing now. But this British physician had estimated that he thought it was about £2 billion a year in free health care that they were given, and about 1 in 20 patients that he was seeing. All right, so when you hear about healthcare and you are being asked to defend free markets in healthcare, just a couple of bullets points. Don't forget, healthcare access doesn't necessarily mean insurance. That's the biggest mistake that a lot of people make. It's not the same thing. Don't forget Porter's discussion about value. It's not just quality or cost. It turns out they're a combination of the two. You wouldn't just get a car just because it was the cheapest car if it didn't have an engine and transmission and a steering wheel and tires, right? You go, look, I got this car cheap, right? Your friends would look at you like you're an idiot. You would want a car that runs, and so therefore you got to look at value when you're talking about healthcare. The most expensive, newest procedure is not always the best. It turns out it doesn't give a return on investment for the dollars spent on it. And yet what you see, particularly in socialized systems, is the constituents are always pushing for, hey, we want the best, the best, the best, the best. Well, it turns out robotic surgery may not, even though it does give slight increases in efficacy from a return on investment standpoint, it's not always the best. Macro level understanding of things, we're going to talk about that, like life expectancy. You'll see that thrown around by statists a bunch, is not really a useful way of describing the healthcare status of a country. And the most important thing, we heard about the morals and ethics of the individual idea, moralities and libertarian thought. This is individual choice. This is ultimate individual choice. It should be individual choice. It's all about liberty and freedom. And do not ever fight tooth and nail when people come for your health care. Particularly socialized healthcare. All right, so 2 other lessons, and I'll go through these kind of quickly. Socialized medicine is horrific. So if you're familiar with the case of Alfie Evans and Charlie Gard in Great Britain, basically 2 children born with very rare diseases. The parents petitioned the physicians and the hospital administrators to be able to leave, to be able to go. They were both, in both cases, were crowdfunded by individuals and said, yeah, we'll pay whatever your expenses are. They could have gone, I think, one or both of them to Johns Hopkins for experimental procedures, which were quite frankly, only available in a couple of hospitals in the world, Johns Hopkins being one, and the British government said no. In fact, I think, I always apologize, I can never remember which one. I think this is Alfie Evans on the left. In fact, they sent the bobbies over to say, basically, you can't take the child out of the hospital or we will put you in a cage or shoot you to death. Welcome to socialized medicine. This is a cartoon that's in a Canadian newspaper. The queues for Canadian procedures are oftentimes weeks and months. And so there's the Canadian people themselves joke about these queues. And this is a case where they say, hey, guess what? A hospital bed just opened up, talking to her recently deceased husband. So don't let people talk you into socialized medicine. All right, so when we're looking at Asian and particularly medical tourism, the free market, the ultimate free market extension of healthcare has been strong in Asia. And so I'm going to just show you a couple of numbers. A lot of this, the modern equivalent of medical tourism, the modern age of medical tourism, has started primarily in the late 90s in countries like Thailand and India and Korea and some other places. And that's kind of the date that we're going to look at in terms of a comparative analysis to determine what has happened in Asia since medical tourism has taken root and grown. So what we've seen is some impacts like the growth in private hospitals and private independent practicing physicians in places like India. You can see it's gone from back in the late 40s, early 50s, about 8% on up to about 85% of physicians and 93% of hospitals and 80% of outpatient clinics in India. India itself has seen very low physician immigration, which is fascinating because we see a lot of Indian physicians around the world. You can go to Dubai, the United States, you're going to see a lot of Indian-born physicians that came there. But actually, if you look at it as a percentage, it's a very low percentage of the total population, meaning something's keeping them there. And in places like Malaysia, they've seen an incredible growth of the medical tourism. In fact, the Malaysian experience, I was talking to a Malaysian healthcare facility that actually has, there's a I think it's a train or a flight, I think it was a flight from Indonesia that basically comes into a local airport, I think it was Kuala Lumpur, and they actually get into a bus. People pile into a bus and they go directly to the hospital. So literally the hospital every day has this bus show up, and then Indonesians pour off the bus to be able to get access to better health care in Malaysia. Data is difficult to find on exactly what's going on in Asia, and some of the different Asian countries have different ways of measuring what is considered medical tourists. Not all of them are what you would say reliable numbers. Some of them exaggerate the numbers. Some of that's because of signaling. Some of these countries actually have a vested interest in trying to encourage more medical tourists. We talked a little bit about why people are traveling. Oftentimes it's going to be for quality, cost, and availability, so that's the most typical answer in Asia. These are some numbers from a survey, not necessarily atypical or typical of what you would see in Asian countries, but they typically are going to be from more affluent countries and less affluent countries, kind of a bimodal distribution. And that's because the more affluent countries are looking for better cost or access to things they can't get. The less affluent countries are looking for more value or quality. And I'm trying to go through this quickly. So this is what I found. So one is, don't let statists and collectivists tell you that the best way to look at healthcare outcomes is life expectancy. There's a lot of economists, some of them very well thought of health economists, for example, that use life expectancy. Any good clinician will be able to tell you there's so much more that goes into life expectancy. People that die in car wrecks, you're going to blame that on the physician? People that die of suicide, maybe a small component, but you're going to blame that on the physician? It does not make any sense whatsoever. So life expectancy, you're going to see that used quite a bit by, again, economists. Those economists, they're statists, okay? They're not telling you the truth, which is that is a horrible measure of country healthcare. There's only a small percentage of total life expectancy that is, and I've seen the research called able to health procedures or health outcomes. And in this Kaiser study said it was about 10% of the outcomes were attributable, life expectancy were attributable to healthcare itself. So this is the data, just got a couple slides and then we'll open up for questions. All right, what I found was when I started looking at some of these Asian countries, basically from the start of medical tourism to about 2015, 2016 for most of these numbers, using primarily OECD data, WHO data, and World Bank data. I found that there didn't seem to be a lot of differences overall. In other words, not significant differences in, for example, healthcare expenditures as a portion of GDP. There didn't appear to be significant differences in the expenditure, healthcare expenditure growth. And again, I'm trying to tease out what's going on. What's the impact of privatization, free market healthcare in these countries where it's become very significant? I did find a slight significant difference between Asian countries and OECD standards in terms of out-of-pocket expenditures. In other words, what we're seeing is there is a greater amount of out-of-pocket expenditures in some of these Asian countries, meaning they're paying cash or some other payment rather than through an insurance or a government program. But then I got to some really good numbers. Unfortunately, I wasn't able to do good statistical analysis because there's a lot of missing data. But the World Bank had some data on the growth of physicians per 1,000 people. And what you find is, I'm going to show you what these numbers mean real quick, is you can see this is China, this is Indonesia, this is India, and this is Korea. I use those as some examples of the of Asian healthcare organizations, and then countries and their healthcare outcomes. But specifically, then what I did was I grouped them into two different groups, which is the receiving countries, in other words, where they receive more medical tourists. That would be obviously Korea and India, and then the sending, which it would be China and Indonesia. And what I found was these interesting results, which is comparing to the OECD, which is red, hard to see, and the world numbers, the growth rate appears to be greater in terms of the number of physicians physicians. And remember, we talked about the Indian example where we're seeing less immigration of Indian physicians out of the country than you would expect. Then I did the same thing with hospital beds. Again, same thing, couldn't do statistical analysis because there was quite a bit of missing data. But looking at the same numbers, what we find is for OECD membership, there's about 66% growth in hospital beds. It's a decline. Sorry, it's 100% would be staying average. So a decline in overall hospital beds per 1,000 people, and also a decline in the world average. But the Asian, both for the send and receive, was higher. Now there's a bit of a regression to the mean effect that could be going on. Some of these Asian economies have been, or economically were developing during this period of time. So that's possible, but there still appears to be something going on. So did a little bit more, let's see, I went backwards. There we go. So two other things I wanted to point out. The growth of private hospitals, a lot of the experiences we see in these medical tourism countries is private hospitals, an increasing number. In fact, even among the poor, if you see this Indian study, found that in this case, 63% of people that were in urban slums gave birth in private hospitals. That's incredible, and that was back in 2011, so it's had a few more years. We found the same kind of example in the United States, where actually, as soon as people got access to PPACA, or what people outside the country often know as Obamacare, it turned out a majority of those people, you end up using those benefits at private hospitals, not public hospitals. So the big advantage of this is, according to several studies, private hospitals have better efficacy, better overall outcomes. In other words, they tend to be better places to go. The last thing then is tangential industries. What we've seen is the growth, for example, in India, of the pharmaceutical and medtech industry. We've seen health IT companies in Asia, and also, there you go, independent laboratories, for example, in China. There does appear to be an impact of all this privatization and free market in healthcare in Asia, but it's been difficult to kind of tease out by itself, but there does seem to be an impact. What the statists are going to tell you, last slide, is that they say this free market, particularly medical tourism, creates its own high-end market, and it distorts the priorities of the government. They're going to say, this is all bad. There's nothing good in this whatsoever. I beg to differ, and I think there is some evidence that there has been positive impacts in many Asian countries from both sending and receiving medical tourists, but we're still trying to figure out exactly what that impact is. But that's all I had. Sorry, I went a little bit over.
Man, that was a really excellent talk and really well presented. Thank you. I just was taken by your comment about how. What's always the latest, newest thing is not necessarily the best thing. And as a surgeon in private practice, it brought to mind a big interference in that is third-party payment systems. So, for example, you mentioned robotic. Robotic surgery was actually originally came about as an attempt to remotely take care of people, and it never really got off the ground because of communications problems. So it got heavily marketed in the United States, and there's a ton of peer-reviewed literature showing basically no advantage of robotic over laparoscopic in most situations. But that hasn't stopped a lot of doctors from offering it as being the latest, and people want the latest, and it costs anywhere from 2 to 3 times the price because the hospitals mark it up. And there's no disincentive to that because the patients don't ask the critical question, which is, well, how much difference does it cost?
Yeah. So great question, great point. So when I was in, I'm going to relay a personal story as kind of an answer. So I was in Severance Hospital, which if you're familiar with Korean hospitals, one of the best hospitals. Arguably, I'd say it's a center of excellence. It's up there with some of the best hospitals in the world. Severance, down the basement, they had, I think it was 3 Da Vinci systems when I visited. It's been like 4 or 5, 6 years ago. And I was downstairs and I saw a couple of Caucasians walking towards me and scrubbing scrubs, and I'm going like, well, that's interesting. You didn't expect to see Caucasians. They were from MD Anderson, and they were like, yeah, we're here actually studying how the Koreans are using the Da Vinci system for treatment of a variety of cancers. And quite frankly, they're the best in the world here, and they had these Da Vinci systems. I think how many ever they had one or two of them that were just for training purposes. They weren't even in production. And by the way, another funny story you'll love. So I got to go into the OR, and one of the Korean surgeons was using the Da Vinci system. He was like, come on over and check it out. You want to look through, and here's how you play. And they were doing like a prostate cancer procedure, and it's like, this is so cool. In the United States, I'd never get this close, right? They'd never let me in the operating room. Anyways, it was in Korea, they've justified the expense because they receive so many people paying cash, and so many people that are willing to pay a premium for a higher efficacy rate that is promised by the Da Vinci system. So that, I think that's kind of the answer. And what's the interesting, if you will, trickle-down aspect of that is by having the machine and the equipment and the procedures and the expertise paid for by these higher margin cash-paying payments, primarily cash-paying payments, or at least private insurance-paying payments. It makes that healthcare technology and procedures available to more people in the community. So I think the Korean healthcare model is that by giving this high-end care to people, they're creating better healthcare for the community that then impacts the entire Korean peninsula.
Cool. Hi, I have a question over here. That was a really interesting presentation with a number of interesting points. And you did mention at one point insurance. And my question is, what is the impact, if any, that medical tourism is having on the insurance industry? And is it keeping up with the increase in demand for medical tourism, or is it falling a bit short?
Yeah, so that's going to be a country-by-country question. So in the United States, we're seeing more and more insurance companies that are trying to figure out how they're going to deal with that. I mentioned the Walmart and some of those large companies, that are doing medical tourism, domestic medical tourism predominantly. Those are self-insured companies. In other words, for their employee base, they handle their own health care, and they have reinsurance to deal with cost overruns. What I've seen is the growth of the international healthcare plans. Many of the large, again, I'm using the American companies, many of the large American companies like Aetna and United have an international plan that they offer. In fact, I heard from a couple people that taking advantage of some of these international plans. So that's been the biggest thing that I've seen, is they're trying to get in the business, get a foot in the business. I think predominantly, if I were to guess, worldwide, the majority of payments to medical tourism-like facilities is on a cash basis.
First of all, I wanted to point out a story of a bone marrow donor being needed in America. And of course, because America despises immigrants, that bone marrow donor was denied entry into America. But the other thing I wanted to ask, what do you think might be done to improve the transportation technologies? Because wouldn't it be great if we could just be like on Star Trek and just beam out when we need health care? And also, where do you think seasteading might come in all of this?
Great question. So let's start with the first one. So I don't have much of a comment on that, except there was, Peru or Chile, one of those has this wonderful, I'm not a big fan of regulatory schemes in general, but this was a funny one. They have, for anybody that rides a motorcycle, you automatically were signed up as an organ donor. And so, yeah, this is hysterical. So the physicians actually call them organ cycles. That's the term that they use for it. Because if motorcyclists, just statistically, if you use an actuarial table, are more likely to die, and oftentimes the cause of death is going to be head trauma, so it doesn't affect the organs. So you have all these wonderful parts that you can utilize. So that's maybe a small status policy that I might put in place if I become emperor. The second, in terms of the seasteading, it'd be fascinating to find out how that would work. There's, oh gosh, help me out, Matt Damon, science fiction movie where the floating islands spacecraft has the really good technology, the table where was it?
Elysium.
Elysium, is that it? Yeah, that sounds right. Did you guys see that? It was fascinating, the idea of having this great healthcare available to people that are willing to pay or pay into a system or a model, and then people, it was a medical tourism story. Essentially, there were people trying to break in to get access to better health care because they wanted access to it. So I don't know how that would exactly work, but I think what you would end up in a free market, you'd have people that would come there because they know that they can make a living. Again, they're driven by their personal motives to be able to make a living. And they would see it in their best interest to deliver high quality care, because if you don't, they'll find somebody else to go to. But yeah, I'm sorry, I'm not a perfect answer.
I thought it was interesting that you mentioned some of these kind of left-wing objections talking about this two-tiered system. It brought to mind a couple of papers that I had read, which I could send you. I have to find them again, but basically it looked at poor people in rich cities and similar poor people in poor cities. And it turns out it's really good to be poor with rich neighbors, better than if you have poor neighbors. The reason is capital accumulation in the hospitals. If they buy a new MRI, the poor person can use it too. Yeah. But if it's all poor people, they can't get the capital to buy the MRI machine. Bam. It's that simple.
Yep, exactly. Thank you. That's Dr. Varner is a very smart man. You can tell that he knows the healthcare system. This is exactly right. So one of the big things, you'll hear a lot of people use like life expectancy in the United States as a reason why the United States is not good at healthcare system. Actually, it has a pretty good healthcare system. Its providers, its medical schools, the hospitals are actually pretty decent overall. We look at oncology survival rates, and they're some of the best in the world. One of the things that we find is that, for example, Japanese, who have one of the highest life expectancies in the world, Japanese people that live in the United States, they live longer than they do in Japan. Wow, right? So, and you take somebody from any part of the world, Latin Americans that move to, you got Colombian, Mexicans, Guatemalans that come to the United States, they live longer than they do in their countries, even in places like Colombia where they have good health care. So it's absolutely right. If you're in a place that values free markets, values competition, values increasing quality in order to meet customer needs, you can end up with better health care. It's a perfect example. Thank you.
I wanted to ask you, because also part of this healthcare tourism is also like dignified death and euthanasia. I don't know how much people are traveling to have a good way to die.
Yes, thank you. Thank you for bringing it up. So we talked about some of the controversial issues. I'm sorry I had to cut slides on time, and I still didn't do well on time, but thank you for bringing up deaf tourism. So one of the most interesting, so you want to hear a great statism story? I didn't put it in this pack of slides. If you're in Poland, you probably heard this story. So a British woman whose husband had terminal cancer, I don't remember what type, was decided to go ahead and book him a stay in Switzerland. There's 2 facilities there. I always forget the names of the places that do doctor-assisted suicide. And so because she did all the planning for her husband, she arranged the travel, she did the paperwork, all that stuff, because he was not able to do it himself. She went to Switzerland with her husband, came back with his remains, and she was promptly arrested at the airport. The British authorities said she had planned first-degree murder, whatever the British equivalent of that is, in Great Britain. So it'd be like, I have a girlfriend, I'm decided to take her to Tahiti, and then, while I'm in the United States, I'm figuring out how I'm going to kill her in Tahiti. You can actually be charged in the United States, even though it's a death in a foreign sovereign country. That's not the case with an unplanned murder. So if it was a murder of passion in Tahiti, I couldn't be charged in the United States. But in this case, the Attorney General, whatever that comparable position is in Great Britain, decided we're not going to win this case. There's no freaking way that we're going to get in front of a jury or a judge and win this, so they dropped the suit. But there are a couple of facilities in Switzerland, and also in the United States. A couple of states have already opened up. There was a young lady that went from California to Oregon to die, doctor-assisted suicide, patient choice, right? Dignity and death. So you may have religious or moral issues with that, but it's healthcare choice, and I'm very libertarian in that respect, in that I do believe that do what you want, have sex with who you want, love who you want, put in your body what you want, and choose the healthcare that you want. There's no reason I should get involved in that conversation whatsoever. So, thank you.
Thank you, David. It was such an interesting presentation.